In the second part of this presentation, I will try to discuss the crestal approach. This approach was first described in 1994 by Summers, and it consists of performing a sinus elevation by the use of the osteotomes through the crest of the ridge. The first step of this procedure is to perform a drilling that will reach the bony floor of the sinus without breaking it. Then, by the use of an osteotome and gentle tapping, we will perform the actual breaking of the floor of the sinus, and then by adding some biomaterial and tapping again this biomaterial, we will have the elevation of the sinus floor until we reach a certain height that will allow us to place the ideal placement in this site. And it is very important throughout this technique to preserve the integrity of the sinus membrane because it will help us preserve the bone graft that was placed into the sinus. If we go back once again to Jensen and co-workers and the consensus conference on sinus that was published in 1998, we would see that the two indications at that time for crestal approach were whenever we had 7 to 9 millimeters of residual bone height or more than 10 millimeters. And in the cases where we had 10 millimeters or more, we had to use, if we follow this consensus conference, the osteotomes with no grafts. And for cases where we had residual bone height of 7 to 9 millimeters, it was stated at that time that we should use the osteotomes with some bone graft and immediate implant placement. We will see throughout this presentation if this classification is still actual. In this case, for example, that fits with a classical indications for internal elevation or crestal elevation, we have residual bone that vary from 6 to 8 millimeters below the sinus. So what we do clinically is after we prepare an initial preparation of the implant sites below the sinus without reaching the sinus floor, the bony sinus floor, we, with the use of an osteotome, as we can see in the radiograph what happens clinically, we tap until we break that sinus floor, and then by adding some biomaterial, we start tapping also the biomaterial, and this will allow us to elevate the sinus membrane and perform the placement of the first implant in this case. And this is the implant placed, and then we start tapping the second implant site in order to perform another elevation to the same sinus but in another implant position. And radiographically, you see the first implant was placed and you see the amount of bone that was grafted into the sinus. And again, you see how this osteotome reached the floor of the sinus, and we can be assured by doing radiographs during the surgery that our grafting material is going into the sinus and it's still protected by the membrane. And this is the placement of the two implants, and this is the radiograph. This was the original height of the sinus, and this is the new bone that was grafted during these procedures. So we went something from 7 to 8 millimeters until we reached 11 and a half, and it was a gain of about 3 to 4 millimeters of bone. From the left side, the same procedure is done again, and you can see that our osteotome is going into the sinus, and you see the amount of bone graft that is placed and that is reaching a level that will allow us to place an implant of 10 millimeters into that sinus. So you see the residual height of the sinus, and you see the new grafted bone with the implant that is very well stabilized and the more than half of this implant is into the sinus inside that grafting bone. So in this case, we gained, I would say, 4 millimeter of bone. So this is the initial position of the sinus, and this is the new position of the sinus. So if we do a radiographic follow-up of this case, 6 months later, we see that the bone is still there and it is starting to get more organized, and it is getting the shape of a newly reorganized bone. Also, from the left side, you can see how the bone was organized, and it is getting more and more mineralized, and you can recognize this by the radiographic aspect of this bone. And this is the case completed. But in such cases, when we need to gain something like 3 to 4 millimeter of bone, the question that arises today is the use of biomaterial in this case useful? Is it mandatory, or we can perform this sinus elevation without the use of a biomaterial? A lot of authors are working on this subject clinically. I will go to this publication by Nadir and co-workers in 2009, who showed in a clinical study the 3-year result of this prospective study on osteotomy sinus floor elevation without grafting material. And they could gain at 3 years a mean bone gain of 3 millimeter without the use of any biomaterial. Actually, I've been using this technique for a while, and if we try to see a couple of cases, like in this case, you see this was the sinus, and this was the implant placed at day 0, at 1 month, at 6 months. You can see the bone that was formed radiographically. But in order to have a more precise idea of the newly gained bone, I added some contrast to the radiographs, and you can see what goes on between day 0 and 6 months. So this was at day 0. You see at 1 month we start having some mineralization of the bone, and at 6 months we have this whole amount of bone that was mineralized above the sinus. So the idea is to place the implant, and by gently lifting the sinus membrane, this will allow for the formation of a blood clot between the implant and the sinus membrane, and the implant will play in this situation a tent-like effect on the membrane, and this blood clot will get transformed into vital bone within the months that follow the procedure. Another case where I have 8 millimeter of residual bone height, and this is the implant that was placed, a 10 millimeter implant, with just by tapping and by breaking that sinus floor and elevated the membrane and placed the implant without the use of any biomaterial. And you can see the stable result at 5 years and the gain of 2 to 3 millimeter that happened in this case. This case also will show us this is the sinus, the initial position of the sinus floor, and you can see the whole amount of bone that was gained here by the placement of an implant into the sinus without the use of any biomaterial. But what is essential in this technique is to avoid any possible damage of the membrane, because if any tearing of the membranes happen, we will not have any bone formation, and we will lose all capacity of this blood clot to form beneath the Schneiderian membrane, and also we will lose any option of having new bone formation, vital bone formation around this implant. So this technique is very predictable today, and in our hands as surgeons, we can perform it on an everyday basis. And what counts today is to have it a predictability over the long term. Like in this case, after 4 years, we see that it's very stable results. And if you go to the results, this is one of the studies. Many studies were published in the literature about the outcome on the long term of osteotome sinus floor elevation, like this 12-year life table analysis on the prospective study of over almost 600 implants. And you can see the survival rate that shows a very, very high successful survival rate in this case. And this is why we can say today that this is a very predictable technique that can be used whenever we had a residual bone height that is diminished in the posterior maxilla. But the question that may arise is, what is the consensus? When should we do a crestal approach and when should we do a lateral approach? What's the optimal residual bone height that we should have in order to perform a predictable crestal approach and a predictable graft into that sinus? In order to answer to this question, I will show 5 clinical cases. And at the end, we will try to conclude and see if there is actually a consensus on when to use a lateral approach or when to use a crestal approach. Like for example, in this case, we have a 5 millimeter residual bone height. Today, with the use of an osteotome, we can try to lift the membrane at the anterior implant site prepared already, and then lift it again on the posterior, and you can see how we have 2 very beautiful dome-like effect. That is the biomaterial that is very nicely packed by the Schneiderian membrane, and this is the implant. Those 2 implants were placed, and this is the situation today. You can see the nice amount of bone graft. We had 5 millimeter, and it went all the way to something like 10 or 12 millimeter of new residual bone height below the sinus. In that other case, I had 4 millimeter. And here also, by drilling until we reach, as we said at the beginning of the lecture, the floor of the sinus, you see that there is always a protective part that is something like 0.5 millimeter or 1 millimeter of bone. By the use of an osteotome with some biomaterial added, we broke that floor of the sinus, and this is the dome-like effect of the biomaterial that is going smoothly inside. You can see now the huge amount of bone that I have inside the sinus. And this is the implant that has been placed. And here also we started with 4 millimeter, and we went all the way until we reached 12 millimeter maybe. And we placed a 12 millimeter implant in that case. In that case, I had 3 millimeters. This case also has a special anatomy because, as you can notice, we have a septum that separates the sinus in 2 compartments. And in case we have to perform a lateral approach, we may be maybe a risk factor because there is a higher risk of tearing the Schneiderian membrane. So by the use of an osteotome, you can see that this osteotome went 2 millimeter into the bone. By adding some biomaterial and tapping smoothly, you see how we start lifting the membrane, and the bone is very well compacted and very well gathered beneath the membrane, because once again of this dome-like effect that you can see here, it's going more up, and now the osteome is going from 2 at the beginning to 6 millimeter into the sinus. And here the osteotome went 8 millimeter into the sinus, and we see the huge amount of bone that is gained, and it's still very well protected by the membrane. And this is the final graft that was performed with 2 implants placed in the anterior region. So we started with 3 millimeter, and we went all the way until we reached maybe 13 or 15 millimeter of new bone height in this region. Here, this is the sinus, and residual bone height was 2 millimeters. And also, with the use of an osteotome that went through this 2 millimeter residual bone height, we went from this small amount until we reached a very nice new amount of bone into the sinus. So going from 2 millimeter to 12 millimeter is also a very nice result when you are using the Crestel approach. And finally, I will show you a case where residual bone height was 1 millimeter only. And in this case, also I decided to perform a Crestel approach. So at the beginning of this case, once we have access to the ridge, we start tapping a little bit until we break smoothly the bony floor of the sinus. We add some biomaterials, and you can see here when we test the Valsalva maneuver that the patient can breathe and there is no tearing of the membrane because there's no bubble coming out of the sinus. And by adding, and it is a slow technique, you have to add biomaterial and go there millimeter by millimeter, millimeter by millimeter, until we reach a proper height of bone graft into the sinus. So you see this is the hole that is performed by the osteotome, this is the added biomaterial, and then by tapping with this biomaterial, with this osteotome, we lift the biomaterial inside the sinus. And this is the final result. This was the hole that was used to insert this bone, this grafted bone. And we went from 1 millimeter to this huge amount of bone inside the sinus. So if we go back to that first slide I showed in the beginning of the presentation, that is the consensus. And if I ask you again the question, what is the consensus? Is it true that whenever we had a 7 to 9 millimeter of residual bone height, we could perform the Crestel approach, and in all other cases we had to perform the lateral approach? Today, after what I showed you clinically, I would say that my new consensus would say that if we had 10 millimeter of residual bone height, we will definitely place an implant, a short implant, and we have a very predictable result with 10 millimeter implant, and there is no need to do a sinus lift procedures. Whenever we had 7 to 9 millimeter of residual bone height, we can perform an osteotome sinus floor elevation with or without the use of grafting material. But we can know, and it is evidence-based today, that you can have very predictable clinical results if you don't use any biomaterial. Whenever we had from 4 to 6 millimeter of residual bone height, also a Crestel approach with an osteotome, but also with the use of a graft, can give us very predictable results, and also we should place immediately the implant because we have enough bone to stabilize this implant. And finally, with the class D that was described as 1 to 3 millimeter, I showed you in this presentation that we could do an osteotome sinus elevation, but also we can do a lateral sinus floor elevation. So it's operator related, and there are sometimes some anatomical factors that may play a role in order to let us as clinicians decide on a lateral or a Crestel approach. We should always use a bone graft in this case, and with 1 to 3 millimeter, we may stabilize the implant, but usually it is better to do a delayed implant placement if we need to have a real predictable result. And finally, I thank you, and I hope that one day we could meet and visit together the cedars of Lebanon. I would like to thank Dental XP once again for giving me the opportunity to present this material, and I would be really happy to have your comments on this lecture and interact through Dental XP with you clinically, and maybe have some future posts and some future clinical discussions with all of our viewers in the world.